in adult psychiatry and stayed on to do a fellowship in geriatric psychiatry. He's board certified in both specialties, adult and geriatric psychiatry. He's on faculty at the Portland VA and Good Sam Regional Medical Center in Corvallis. His practice involves outpatient clinics as well as nursing home consultation. He's actively involved in medical student and resident teaching up at OHSU, and today he's going to be speaking to us about adult ADHD. Thank you so much.
Thanks. Hello. So a couple of questions before I get started. How many of you treat adult ADHD? Okay. And how many of you feel comfortable treating adult ADHD? Okay, good. And what are your specialties? How many generalists in the clinic are here? And how many specialists? And what specialties? I know endocrinology. Pediatrics? Oh, psychiatry. Okay, so I have psychiatrists in the audience. Okay, good. Well, let's get started. So I'm going to talk about diagnosing and treating adult ADHD. And there are nuances in comparison to pediatric ADHD. And I'm going to talk a little bit about the differences between the two, but I am not a pediatric psychiatrist. And so I want to make the disclaimer that this talk pertains specifically to diagnosing and treating ADHD in the adult patient population. I don't have any disclosures. I'm going to start out by talking about the epidemiology of ADHD in the adult patient population. We'll talk about clinical features, how ADHD presents in adults, and I will make some comparisons to the way that it presents in the pediatric population. I'm going to talk about screening tools. I might, there's one screening tool that you may or may not be using. I think it'll probably be new to you, so I want to spend some time talking about that screening tool. And then we're going to spend time talking about treatment and treatment challenges, because I think very often when we treat adults who have ADHD, there are a number of challenges that come up in the treatment. And it is one of the most common psychiatric disorders in the pediatric population. The prevalence is about 11%. About a third to maybe a half of those cases persist into adulthood. And there's a 4.4 prevalence of ADHD. There's a 4.4% prevalence in the young adult patient population. So it's not by any means an uncommon psychiatric disorder, and it's important to think about in the patients that you treat. And there is evidence for a genetic basis for the disorder that's supported by family and twin studies. The risk of having ADHD is elevated 3- to 5-fold in a person with a first-degree relative who has the disorder. And twin studies show a concordance rate of up to 90% in monozygotic twins. And where I find this helpful is in gray area cases when I'm treating someone who's coming to me with a chief complaint of ADHD symptoms, and it's not quite clear, it's not a slam dunk case for ADHD, but there is a strong family history. That might lean me more toward making the diagnosis. So I do think it's important to be aware of the epidemiology of the disorder and the increased risk in patients who have family members with ADHD. It's a biologically based disease, but the pathogenesis is not well known. But it's thought to be due to dysfunction of frontal subcortical circuits that use catecholamines as the primary source of neurotransmission. And these pathways in the brain are responsible for modulating emotion and cognition through behavior and movement. And ADHD really is a disorder of emotion, of cognition, of behavior, and often of movement. And so the medicines that we use to treat ADHD increase brain levels of norepinephrine and dopamine, and we'll spend time toward the end of the talk discussing ADHD treatments. But I do want to stress that it really is a biologically based disease. I think there is a lot of skepticism about the validity of the illness. But in non-ADHD disorders where there is damage to these brain circuits, we see symptoms that present very similarly to ADHD. So, patients who have traumatic brain injury that's affected the frontal lobes or other central nervous system disorders that affect these brain circuits. And so when these circuits are disrupted, we see impairments of tests of sustained attention or vigilance, perceptual and motor speed, working memory, verbal learning, processing speed and response inhibition, which really is these are the hallmark symptoms of ADHD. And it's a disorder with two core categories of symptoms. How many of you are familiar with the two core categories of symptoms? So there's an inattentive presentation, or inattentive type is how it was referred to in the DSM-4. The DSM-5 updated the terminology from type to presentation. There's an impulsive and hyperactive presentation. And then more commonly, there's a combined presentation where we see combined features of both inattention and impulsivity and hyperactivity. In adults, as opposed to pediatrics, we tend to see more inattention symptom presentations. And when hyperactivity and impulsivity are present, they don't present similarly to the way they do in children, which we'll talk about in just a little bit. And I want to start out by saying that one thing I enjoy about assessing for and treating people with ADHD is that the assessment is very difficult. And I don't know if you guys would agree with me. Would you agree with me? Yes. I think it's challenging, and I enjoy the challenge. And it's challenging for a lot of reasons in the adult population. As adults, we have complex and chaotic lives. And so there's this background noise that can influence how the person presents to the clinic. It can be unclear whether or not the person's distractibility or inattention is due to anxiety related to psychosocial stressors, or due to other medications that they may be taking, or due to co-occurring medical illnesses, or due to co-occurring psychiatric illnesses. So as we age, we accumulate all sorts of confounders that can make the diagnosis of ADHD difficult. And the other thing that I think makes it a challenging condition to assess is that the clinical presentation in adults doesn't often match up with the DSM-5 diagnostic criteria, and there's a reason for that. Does anyone know the reason? And it's a good reason. The diagnostic criteria were developed for use in children, and adults don't present, don't behave, don't have the same lifestyles of children. So the way the disorder presents in adults is going to be inherently different than the way it presents in children. One person said you don't grow out of ADHD, you just get better at coping with it. And I think that speaks to the fact that age brings wisdom and insight, that the impact of ADHD on a person's life can be modified by tailoring their environment to be ADHD friendly. So you might not have a full-blown symptom presentation in an adult who's tailored their life to accommodate and minimize the impact of ADHD on their life, but they may not be achieving their full potential. A person who is incredibly intelligent but burdened by ADHD symptoms may not achieve the same professional level of success that they would if their ADHD was treated. So they may work in a field where attention and hyperactivity are not needed. So they may work in sales, or they may work doing outdoor. They may be a laborer in the outdoors. Something that doesn't quite match up with their level of intellect, but does match up with their with their ADHD. And the other thing I want to point out is that secondary gain is a consideration in kids and in adults. The medicines that we use to prescribe ADHD are highly habit-forming. They have street value. They are regulated by the FDA. The stimulants are Schedule II drugs. And so it's not uncommon for an adult to divert the medication for sale to other people on the streets, or to misuse the medication. So we always have to think about the possibility of secondary gain before we treat someone with ADHD. And so we'll start with the case, and I'll thread this case through the talk. And our case is of John. He's a 21-year-old college student who was referred for an ADHD evaluation. We can just say he's in the primary care clinic. He reports a history of ADHD that was diagnosed at age 8 but never treated, which is very common. He's currently struggling to maintain a passing GPA in college, and describes procrastinating, poor attention, distractibility, and he tends to say whatever's on his mind quite a bit, and this gets him into trouble at work and at school. And so you can already kind of see from this history that there are features of inattention, and there are features of impulsivity and of impulsivity. And so this sounds a lot like ADHD, right? But then you get more history, and he describes, well, I've got this history of depression. I use marijuana regularly. He's got untreated sleep apnea, moderate severity. He's also got knee pain. He takes a multivitamin and Vicodin, PRN. You do a social history, and he tells you that he lives with his girlfriend and her 4 children, ages 1 through 8, 2 of whom who have special needs, and housing is unstable. Not so clear-cut after all, but much more realistic in terms of how patients present to us than the nice, clean symptom presentation. And so, I think this kind of speaks to the need to dig further than just exploring the chief complaint when you're doing an ADHD evaluation. So what we do when we do an ADHD evaluation is we should assess for specific symptoms, including when they started, remembering that this is a neurodevelopmental disorder that starts in childhood. Symptoms need to be present in childhood. We want to know about the severity of the symptoms, the frequency of the symptoms, and the situational specificity. It is important when making the diagnosis that we, as much as possible, use the DSM diagnostic criteria, which does require that the symptoms be present in more than one location. So in a kid, we think about home and we think about school. In an adult, we think about home, we think about work, we think about relationships, places where they may engage in hobbies or things like that. And so part of your assessment includes a functional assessment that looks at school, if your adult is an adult learner, that looks at their employment history and that looks at their performance or how well they do or don't do in those different environments. So that's kind of the umbrella view is that you're looking for specific symptoms. You're looking at when they started, how severe they are, how frequently they occur, and where they occur. And what you're looking for is a persistent pattern of inattention or hyperactivity and impulsivity that's present in more than one setting and interferes with function. So that's kind of that's sort of the benchmark that you're looking, the overview benchmark that you're looking for when you're doing an ADHD assessment. And we're going to talk about those specific symptoms that you assess for, but I want you to keep that overview in mind. And one thing I want to point out is the difference between real and perceived impairment. And I think where I'm going with this, that perceived impairment would be the person who comes to you and says, I'm working full-time, I'm married with children, I'm struggling to keep up with my executive MBA program, I think I have ADHD. And this is kind of I think, part of the art of medicine. There's no textbook that's going to tell you the difference between real and perceived. You do have to rely on your clinical judgment for this. And this is an extreme case. Most people are going to struggle in a situation like this. Now, if this person gave you a history of this type of difficulty that began in childhood and has been pretty persistent throughout his life, that might lend you to think about real impairment as opposed to perceived impairment. So my rule of thumb is, if I think almost anybody's going to have difficulty in a situation like that, it's probably more perceived impairment than real impairment. And not that perceived impairment isn't a problem. It is a problem. It can be a problem, but the way I would approach treatment would be different than in someone who has real impairment due to ADHD. And so an example of someone with real impairment would be the person who can't maintain employment because they're not able to do simple job requirements, like turning in a timesheet or completing reports or doing other job duties, and that it's a pretty sort of consistent and persistent problem in almost any job that they've had, and that problem carries over into home, or it carries over into social relationships. So continuing with the assessment, it's important to inquire about the person's past psychiatric history. There is a lot of symptom overlap between ADHD and other psychiatric disorders, which we'll talk about. The medical history is very important as well because a number of medical conditions including medications, can mimic ADHD in terms of the effect on a person's cognition. Family history, I talked about earlier, and social history is really important as well because it's through the social history that you might be able to fully elicit the functional impairment or the effect of ADHD on that person's life. So social history is important. And then I find collateral to be really useful. Very rarely do I rely on the patient as my sole source of the history. If it's a younger adult, I will try to talk to mom or dad or try to get school transcripts. If it's an older adult or a young, sort of middle-aged adult, I try to talk to a family member who might be able, a spouse or, potentially a sibling who might be able to say, yeah, this is happening currently at home, and the sibling might be able to say, yeah, that was going on when your patient was younger. So I find collateral to be really, really helpful, especially in the gray area cases. Another thing I want to mention is that it's not an all or none condition. The people who have ADHD can pay attention, exercise self-control, and complete tasks when faced with a deadline or doing something that they really enjoy doing or are under close scrutiny. So, this is kind of a spectrum in terms of the impact of the disorder on a person's life. I've had patients referred to me by primary care providers, with the caveat that they want you to evaluate them for ADHD, but they have a graduate degree, so I don't think that they really have ADHD. And so the ability to achieve some level of success or to perform academically does not rule out the possibility that the person has ADHD. What you often find is that these people have to work a whole lot harder than their peers to perform well or to achieve success. So just because a person is accomplished doesn't mean that they can't possibly have ADHD. So what we're looking for is whether or not the ADHD symptoms are typically present and more pronounced when there's less external structure and less demand. So let's talk about the diagnostic criteria. The DSM-4 was replaced by the DSM-5 a couple of years ago. And how many of you, besides the psychiatrist, are familiar with the DSM-5? So I think most of you guys, this is sort of the diagnostic textbook that contains the symptom requirements for making a diagnosis of a psychiatric disorder, and ADHD is included in the DSM-5. And luckily, the symptom criteria have not changed, and there are 18 of them. They've not changed between the DSM-4 and the DSM-5, which is great because that means they've got good validity. And it also means we don't have to memorize a new set of diagnostic criteria, more importantly. And the DSM-5 says, in order to make the diagnosis, there needs to be 5 or more symptoms of inattention and or 5 or more symptoms of hyperactivity or impulsivity, and that these have to interfere with the person's functional abilities. And the DSM-4 used to require that these symptoms be present prior to the age of 7, but in the DSM-5 they've expanded that, or they've softened that criteria and said, the symptoms need to have been present prior to the age of 12, which is really useful because it's hard to elicit symptoms from a person who, we're not likely to remember symptoms, that we did or didn't experience in, our ages, 1 through 5. So it's easier to remember back to 5th grade than it is 1st grade. So that's useful to keep in mind, that no longer do we have to go back to 1st grade and earlier. When taking a history, we can just go back to 6th grade. And so our key features in the disorder are hyperactivity and impulsivity, which we're going to talk about, and those are and inattention. These are well delineated in the DSM-5. And I want to spend time talking about symptoms that are not in the DSM-5, but are predominant in the adult ADHD population. And one of them is executive dysfunction, which we'll talk about, and the other is emotional dysregulation, which we'll also spend some time talking about. So hyperactivity is exactly what you think it is. It's a person who's got they're hyperactive. They are fidgety. They have trouble remaining seated. They might be described as, on the go. They run or climb in inappropriate situations. They're unable to play quietly. You can kind of see how these are describing symptoms in children. Some adults do those things, though. Talk excessively, and then with impulsivity, difficulty waiting your turn, blurting out answers, interrupting other people in completing their sentences, intruding on conversation. So these are the 9 hyperactive and impulsive symptoms in the DSM. In the DSM-5. And so I want to spend a little bit of time talking about how it might look differently in children than in adults. And on the left is how these symptoms would present in children. On the right is how they would present in adults. So hyperactivity, it's not common that an adult is going to be hyperactive, especially in a work or social situation. Adults tend to be better at controlling the urge to act on their hyperactive impulses, so they may want to get up and run around or climb a tree, but they don't. And so, when we try to contain our impulse to do something, and if we have to really kind of hold on to that containment for a long period of time, it's probably going to make you feel restless. And so this is how hyperactivity tends to present in adults differently than in children. So, the adult might describe feeling very impatient standing in a grocery line, or very impatient or uncomfortable sitting through a 50-minute talk on ADHD, or sitting through a movie. And when you experience this restlessness and this difficulty, it can lead to irritability and mood swings. And so this is where that emotional dysregulation in adults tends to be a common way that ADHD can present. And with this irritability, with these mood swings, can come trouble in relationships, trouble maintaining jobs. So when I think about hyperactivity in adults, I think about restlessness more than I think about sort of classic hyperactive symptoms that we would see in children. And adults, for the most part, tend not to be physically impulsive because of the ability to sort of exercise self-control, but it may be more difficult to control or contain verbal impulsivity. So adults tend to be more verbally impulsive, whereas kids tend to be more physically impulsive. And this isn't hard and fast, these rules, but it's just more of a generality, that if I were to ask an adult about, classic hyperactive symptoms, I might miss the diagnosis. And so I tend to focus also on the assessment of restlessness and the effect that it has on a person's patience or on their employment or relationships. Inattention describes the inability to stay focused on a task. And attention is not a unitary construct. There's sustained attention, divided attention, selective attention. And ADHD really does impact all aspects of attention, but tends to impact sustained attention the most. And so through inattention, the adult may have difficulty paying attention to details, which can lead to problems at work or problems at home with things like paying the bills. Trouble sustaining attention. So, anything that requires, sustained attention, whether it's a lengthy reading or doing taxes or paying the bills, tends to be a real problem, and they may procrastinate doing it because they know that, gosh, this is going to be really difficult for me to do. And other inattention symptoms, starting projects but getting sidetracked really easily. And so asking a person about, projects that they have going on can be high yield, or asking their significant other about, if they have one, about, what does the garage look like? What does the office look like? Do they tend to start a lot of projects and then get distracted? And so usually you'll have an exasperated significant other, who says, oh my gosh, if you go into their hobby room or the garage, there's so many things going on, and he or she never finishes any of them. Trouble with organization, avoiding activities that require sustained attention, which I mentioned earlier, losing important things regularly and repeatedly, getting distracted easily, and then forgetful in daily activities. And then again, as with the other slide, I just want to point out some differences between how ADHD, how the inattentive symptoms present in adults than in children, though they are very similar. It really is more the context that's different. The kid with ADHD struggles with schoolwork or struggles with attention in class, whereas the adult has a similar set of problems, but often out at work. The things a kid is forgetful for are going to be different than the things an adult is forgetful for. So rather than chores, errands, and schoolwork, the adult may struggle with appointments or returning phone calls or paying bills. And then the kinds of things that a kid loses is often different than the kind of things that an adult might lose, like wallet, keys, cell phone, as opposed to pencils, paper, and homework. And I mentioned earlier executive dysfunction, which is not in the DSM-5, but is undoubtedly impaired in adults who have ADHD. How many of you are familiar with the term executive dysfunction? Most of you, so it's kind of higher level cognitive function. It's mediated by the prefrontal cortex and involves things like sequencing information, organizing, abstracting, planning. It really is what allows us to function in life as adults. And adults who have ADHD often struggle with executive function, and this tends to be a real problem. And where we see it as a problem is, managing time, organizing their life, and so it goes really beyond the hyperactivity and the impulsivity, but and really kind of threads throughout all aspects of the person's life. And so, often on social history, you can uncover a person's difficulty with executive function because it tends to translate into, struggles in relationships, struggles in employment, struggles in school. And then emotional dysregulation is really common as well. I mentioned, when you're containing the urge to act on your impulsivity, it can lead to mood lability, anger outbursts, low frustration tolerance. And often this is the chief complaint in the clinic. I wouldn't diagnose ADHD based solely on that, but it might raise a red flag for me, especially if I take a social history and it seems like this person's really never managed to succeed academically or occupationally. If the chief complaint is, a mood swing or irritability or relationship troubles, I would then likely move on to screen the person for the possibility of whether or not ADHD might be contributing to their symptom presentation. And that being said, in this study that was published about 13 years ago, it was a telephone survey, and the authors found that in comparison to adults who did not have ADHD, adults with ADHD were more than twice as likely to have been arrested, more than twice as likely to have been divorced, more than twice as likely to have dropped out of high school, and more than twice as likely to have held 6 or more jobs in the past 10 years. And so I think that speaks to the extent to which ADHD can impact a person's life. And this is information you would get on the social history, and that's why the social history is incredibly important when assessing a person for ADHD. And in this study, the authors compared young adults' driving skills with and without ADHD, assessed by driving violations. And the red column represents people with ADHD, the blue column people without ADHD. And they found that the young adults with ADHD struggled a lot more to drive safely than the young adults without ADHD. And the interesting thing about this is they tested driving knowledge, and they found that there was no difference between the groups. So knowing what to do wasn't the problem, but doing what you know was the problem. And that really is often what we see in ADHD is the inability to do what you know you should do, or what you're supposed to do. So screening instruments can be really, really useful, not only for screening for the disorder, but also tracking response to treatment. And the screening instrument that I use, and it's recommended by the World Health Organization, is the Adult ADHD Self-Report Scale. Does anyone use this? It's free. You can Google it. There's a PDF online, and you can print it off and give it to your patients. And it's been validated and shown to be effective in primary care settings. And it essentially has the 18 symptoms pulled from the DSM-4. And the patient would check whether or not they have symptoms based on the frequency. And I find it to be really useful. And what I often find is that when a person gets treated with ADHD, that their performance on this screening instrument tends to improve. And so it can be useful to track response, successful or unsuccessful response to treatment. Another common rating scale is the Conners Adult ADHD Rating Scale. I don't know if anyone uses this. It's not free. It does cost money, and it's really long, and it really isn't any more sensitive or specific for diagnosing ADHD than the Adult ADHD Self-Report Scale in the adult population. And so I don't use it, but it is available and widely used in the pediatric population. And the rating scale that I really like, and I think most people don't know about, is the Wender Utah Rating Scale. Has anyone ever heard of this or come across this? And the reason I really like this is because it's unlike any other ADHD rating scale because it assesses symptoms in childhood. And remember, ADHD is a disorder where we have to establish whether or not the symptoms were present in childhood. So there are 61 questions, and the adult is asked to say whether or not those symptoms were present in childhood. And 25 out of these 61 symptoms are highly correlated with ADHD. And so you would look at the 25 symptoms that are correlated, total up your score, and then determine whether or not it meets the threshold. And I like this because, I think the other rating scales are very obvious. Let's say the person is wanting a stimulant prescribed for reasons other than treating ADHD. It's very easy to feign a positive performance on any of the rating scales, with the exception of the Wender Utah Rating Scale. And so I use it. It's free. Again, you can Google it and get a PDF. And I find it super helpful for making the case of ADHD, particularly in someone who doesn't really give a clear history. What about in-depth neuropsych testing? Does anyone ever refer to a neuropsychologist for help with diagnosing ADHD? And I don't usually either, so no hands went up. There really isn't a gold standard battery of neuropsych testing that's used to make the diagnosis of ADHD. And there's no real sort of consistent pattern of performance on a battery of neuropsych testing that is useful in making the diagnosis. That being said, people who have ADHD do struggle in particular cognitive domains on in-depth neuropsych testing, and it can be useful to determine which cognitive domains they struggle most with, particularly if you want to develop a cognitive rehab plan. So, if someone is not responding that well to a stimulant medication, and I want to know, what aspects of their cognition, they're really struggling with, neuropsych testing can be useful. And when I make a referral then to a cognitive rehab specialist, speech pathologists, some of them are trained in cognitive rehab, that information can be useful in targeting those areas where they struggle and coming up with a supportive plan. And then the question I get asked a lot is, can these tests be feigned? And the obvious answer is yes. It's very easy for someone to say, oh yeah, that sounds like ADHD. That sounds like ADHD on the rating scale. And so I would never rely solely on the rating scale as my only sort of way of making the diagnosis. I use it to support the diagnosis of ADHD based on the clinical history. And then, it was actually studied whether or not these tests can be feigned. In this study published in 2007, the authors compared honest normals, so people who did not have ADHD and were honest about their symptoms, with fakers, so people who did not have ADHD but were intentionally faking ADHD symptoms, and then those who really did have ADHD. And they put them through a couple of screening instruments and a couple of cognitive tests. And what they found, not surprisingly, is that the fakers couldn't be distinguished from the people who really did have ADHD. And that is a little bit discouraging, but that underscores the importance of not relying on the screening instrument or the rating scale as your sole way of making the diagnosis, but using it to either support or not support the diagnosis based on the person's clinical history. So that's up there in red as a reminder that that you shouldn't rely solely on a rating scale to make the diagnosis. And the other thing that's important to do as well is to assess for co-occurring psychiatric conditions, because there is high comorbidity between other psychiatric disorders and ADHD. And other psychiatric disorders can sometimes look just like ADHD. So not only is there comorbidity, but you can make the wrong diagnosis if you don't consider the possibility of other psychiatric disorders. So mood disorders, like depression, if you look at the diagnostic criteria for depression, poor concentration is in there. Trouble making decisions is in there. If you look at the symptom criteria for mania, hyperactivity, impulsivity, which share symptom overlap with ADHD. Anxiety disorders have irritability, have restlessness, have poor concentration in their symptom criteria. And substance use disorders, both states of intoxication and withdrawal, not only co-occur, but also might mimic ADHD. So it's really important to assess for the possibility that a different psychiatric disorder may account for the symptoms that they're presenting with, or that the other psychiatric disorder may be co-occurring with ADHD and making the ADHD symptoms worse. And so, in circumstances like this, I often want to rule out the psychiatric condition which may be causing or contributing first, and I want to treat that first. So if someone, is presenting with ADHD symptoms, but they've got untreated depression, I will typically treat the depression first and see how those ADHD symptoms do over time as the depression is treated. Similarly, with other psychiatric disorders as well. And we'll talk a little bit about substance use, specifically marijuana. What do you do when someone is consuming marijuana and they're presenting to you with ADHD symptoms. So, if you decide to treat the ADHD as well, just make sure that you're also treating the co-occurring psychiatric disorder, because you may not get full symptom resolution if you don't address the other psychiatric disorders. And in complicated cases like this, I think it would be very reasonable to refer to a psychiatrist for assistance, because these can be very complicated even for a psychiatrist. So don't hesitate to make a referral when there are these confounders that are present. So what about marijuana? The landscape of medicine is very different in this era of recreational, legalized recreational use of marijuana. It used to be very easy to say, well, don't, when you say don't use marijuana, well, why shouldn't I use it? Well, because it's illegal. We don't have that option anymore. And chronic and frequent use of marijuana can impact attention, learning, psychomotor speed, things that we see impaired in people who have ADHD. And so this can be, when someone's coming to you and they're saying, I've got ADHD, I've got these symptoms. Maybe they do, but they're also using marijuana heavily and regularly. I let them know, you want me to help you to treat these specific symptoms, but the marijuana use is making those symptoms worse. And that's kind of my route in with beginning to talk to the person about reducing their use of marijuana, not just sending them away and saying, well, you're using marijuana, so forget about it. But I want to, that is important to address with them, that, maybe these symptoms are impacting their life, but the use of marijuana might be making that worse. So before we even begin talking about treating the ADHD, let's start by reducing the use of marijuana and seeing how these symptoms then do. And it's important, I think, to address it from that angle, because there is high comorbidity between marijuana use and people who have ADHD. So again, the presence of one doesn't exclude the possibility of the other. And my general rule of thumb is, if the marijuana use is heavy, and I think is part of the reason they're having the symptoms that they're having, I start there first. If they're using marijuana, responsibly, if there is such a thing, then I might be more comfortable initiating treatment for ADHD if I feel really confident about the ADHD diagnosis. And so, what is responsible use of marijuana? If they're not using it every day, if it's not causing problems in their life outside of, the symptoms that they're presenting to you with, then that, in my mind, constitutes, okay, well, let's just go ahead and give it a try. And often what you find is that with successful treatment of ADHD, the use of recreational or illicit drugs does tend to get better. And then some medical conditions that can mimic ADHD, pain, untreated sleep apnea, thyroid disease, traumatic brain injury, history. This is not an exhaustive list, but do be aware that there are medical conditions that can mimic ADHD. So my basic workup is a TSH if a person hasn't had one, or there's a family history of thyroid dysfunction. I do a chemistry panel in my patients, a CBC, kind of the standard psychiatric workup, and then I always try to do a urine drug screen to make sure that that they're not using illicit or recreational substances. And then the cardiac workup, I think, is really, really important. There are case reports of sudden cardiac death in people who are prescribed stimulant medications. And the FDA almost placed a black box warning for this reason. But a few years ago, in 2011, there was this really, really big retrospective study. I think they looked at 300,000 people. I think about half were on stimulants, half were not on stimulants. And they actually found that the stimulant group did not experience any higher cardiac morbidity than the non-stimulant group, which is really reassuring. But that being said, there are known cases of people who have died shortly after being put on stimulants. And often those people have some type of a structural cardiac condition, which is why I listen to the heart of every patient that I start on a stimulant. And if they're over 40, I will get an EKG. Or if they're younger than 40 and they have a personal or family history of cardiac disease. And stimulants can increase blood pressure in a dose-dependent manner. So I check blood pressure before I start a stimulant, and then I follow that with every dose increase to ensure that I'm not causing an elevation in blood pressure. So going back to our case, John says, hey, I am using my CPAP or BiPAP. My mood symptoms are controlled. I'm not depressed. I'm not using marijuana every day, just once a week to help with knee pain. You get collateral history. The girlfriend confirms it. You talk to the mother. The mother says, yes, he was diagnosed with ADHD in childhood. So you decide, okay, let's initiate treatment with the stimulant. So how do you begin to initiate treatment? I start, again, by checking vital signs. I do check a weight because stimulants can cause appetite suppression and weight loss. And I do check a urine drug screen. And in John's case, it was not surprisingly positive for THC. So when I start treatment, my goal is not just to reduce ADHD symptoms, but also to improve function. So very similar to the way we prescribe opiates, that we're not just looking for improvement in pain, but we want to see improvement in function. Likewise with stimulant medications. And there are two classes of medicines that we use to treat ADHD. There are stimulants, which are the first-line treatment for ADHD, and there are non-stimulant options that are available, which we'll talk about. And then I find cognitive rehab therapy and environmental interventions to be useful, not as a primary way to treat the disorder, but as an adjuvant therapy to whatever medicine I might be prescribing. And just keep in mind that it can take time for symptoms and response to treatment to play out. Often symptoms, those 18 diagnostic criteria symptoms, tend to improve pretty quickly, but function might lag behind. A person who's had a lifelong history of trouble maintaining employment or relationships might not realize the benefit of ADHD treatment. We might not see the benefit on employment and on relationships for months to potentially years after a person's been experiencing good control of ADHD symptoms. So we'll talk quickly about stimulants. There are two categories. There's methylphenidate or Ritalin, which I think most people are familiar with, and then there are the amphetamines. And the two amphetamines, the trade names are Adderall and Dexedrine. And they both work the same way. And like SSRI antidepressants, one, there's not necessarily a way to predict which stimulant a person is going to do best with. So like SSRIs, we kind of start one, see how they do. If they don't do so well on that stimulant, we'll try a different stimulant medication. And you guys, there are a ton of formulations and delivery systems. I can't even keep track of how many versions and variations of methylphenidate there are and of the mixed amphetamine salts. And so I think what's really helpful is to just get familiar with one formulation in each category, both a short-acting and a long-acting, and just have that as your go-to medication. And if you've exhausted what you're familiar with, referring out to a psychiatrist could be useful at that point. So methylphenidate, just some of the different brands of methylphenidate that are out there, long and short-acting formulations. Dextroamphetamine is Dexedrine, and the mixed amphetamine salts are Adderall. And then a newer player is Vyvanse or lisdexamphetamine. This is only available in a long-acting. It's just a once-a-day medication, but dextroamphetamine and the mixed salts do also have short and long-acting formulations. So just get familiar with one or two stimulants in each category and use it. There's nothing to guide us in terms of which one is going to be better for a particular patient than another. And a general rule of thumb in terms of dosing is methylphenidate is not as potent as the amphetamines, so about 1 milligram per kilogram of body weight. In kids and adults, sometimes we go higher, and 0.5 milligrams per kilogram of amphetamine preparations. Again, in dosing guidelines in kids and adults, you can go up a little bit higher. They do cause side effects: dry mouth, insomnia, irritability, psychosis at doses that are too high or in a person that's predisposed to psychosis, elevation in blood pressure and pulse, headaches. And then I know we're not using pregnancy class scales anymore, but historically they were pregnancy class C, so there really aren't any studies that show safety or lack of safety in pregnancy. And a lot of what we know about amphetamines in pregnancy come from the use of illicit amphetamines during pregnancy, and they are associated with both maternal and fetal morbidity, premature delivery, low birth weight, miscarriage. So I don't prescribe them. I don't prescribe them to people, to women who are pregnant. I think it's very hard to make the case that the benefit really ever outweighs the potential risk. And there are some patients for whom I won't prescribe a stimulant. Someone who's got uncontrolled hypertension, any serious arrhythmia, symptomatic heart disease, a recent cardiovascular event, or a person who's actively using drugs or in an unstable period of sobriety. There are alternatives to stimulants in circumstances like this. It can be useful to use a treatment sort of contract in people who you're starting a stimulant on. How many of you use treatment contracts for opiate prescriptions? So most of you, at the VA where I see some patients, our contract was modeled on the opiate prescribing contract. So if you want to use a contract, you can kind of change the terminology from opiates to stimulants and change the risks to tailor it to risks associated with the use of stimulants. So John comes back. We're going to start him on methylphenidate. Kind of pick your poison, methylphenidate or an amphetamine. I usually start people on methylphenidate, and the starting dose is low: 5 milligrams in the morning, 5 milligrams in the afternoon. And then I usually have my patient self-titrate a week later if they're tolerating it and they're not seeing symptom improvement to 10 and 10. And then I usually see them in clinic 2 weeks later to see how they're doing. And so I typically start with a fast-acting formulation because of dosing flexibility. The duration of action is short, 3 to 5 hours, which is why we do this BID dosing. And typically the second dose is not after 4 p.m. because it can impact a person's sleep. So I tell the person, separate the doses by 4 to 6 hours and don't take the second dose after 4 p.m. And they're usually going to see response to the medication within about an hour. So this isn't like an SSRI that's going to take weeks to play out. We should know how a person's doing on the medication within days. And if you find a dose that works really well for them, let's say it's 20 in the morning and 20 in the afternoon of methylphenidate, and they say, but I always forget the afternoon dose, you can then switch them over to a long-acting formulation. And I show this curve to my patients. I tell them that for stimulant medications, our goal, if task performance is on the y-axis and dose is on the x-axis, is to get them here. And anyone who goes on too high of a dose of a stimulant, you're going to get the opposite effect. It's going to make them jittery and nervous, worsen their attention, and potentially induce psychosis. So our goal is to find the person's optimal point on this particular curve, and it's going to be different for different people. So John comes back to us. You check his blood pressure and pulse. It's normal. He says, I'm doing a little bit better, but there's room for improvement. So you titrate up in 5 to 10 milligram increments every week, and you see him back after a week. And one treatment challenge that I find in people who get up to these higher doses of stimulants is that they experience a peak-valley effect, that they notice the medicine within 1 to 2 hours and it works really well, but by the 4th or 5th hour they start to feel it wearing off. So they take the second dose and similarly get this sort of peak effect that tapers off through the evening, and it can lead to fatigue or potentially dysphoria. And so in those circumstances, I think switching them to a long-acting formulation is very reasonable to do. Similarly, in the person who forgets that afternoon dose. And then if the person is not tolerating the stimulant because of a side effect, like an SSRI, you would just switch them to a different stimulant and see how they do. So to illustrate that, John comes back and he says, it's working, but I've got headaches at this higher dose. So you check the blood pressure to make sure that this isn't because of hypertension. And in his case, it isn't. So your option is to switch him or her to a different stimulant. And if you're going from methylphenidate to an amphetamine, don't do a 1-to-1 conversion. You would want to dose down by about 50% because the amphetamines, again, are more potent than methylphenidate. In the person who may be asking for early refills frequently on the medication, or who might not have that methylphenidate show up in their urine drug screen and you're concerned about diversion, but you think they really do have ADHD, you can treat with a non-stimulant. Strattera is a non-stimulant medication that can be used to treat ADHD. It's FDA approved. Like an SSRI, however, it does need to be taken every day for treatment effect. It can elevate blood pressure, so I do a similar cardiac workup in people that I'm starting on Strattera, and it can cause anything from a mild transaminitis to fulminant hepatic failure based on case reports. So I do monitor LFTs in people who I put onto Strattera. Bupropion or Wellbutrin is adequate second-line therapy for people who have ADHD and can be really useful in someone who's got co-occurring depression. And tricyclic antidepressants and venlafaxine also have some evidence for efficacy in treating people with ADHD as second-line therapy. So they're reasonable to use in someone for whom you don't want to prescribe a stimulant. And then the alpha-2 agonists, clonidine and guanfacine, it's not clear how effective they are in adults, but they are used pretty commonly in the pediatric population, particularly for impulsive and hyperactive symptoms. Practical strategies that I talk to all of my patients about along with the prescription, the importance of maintaining a daily schedule, keeping a to-do list, limiting distractions, scheduling attention-demanding tasks, breaking down difficult tasks into palatable pieces, and dedicating a quiet space for studying or getting things done. So to wrap up, we know it's a heritable condition. It starts in childhood and persists into adulthood, so there's no such thing as adult onset ADHD. The diagnosis is really made clinically, and we have very effective treatments, starting with stimulants, though there are second-line medicines that are available in a person for whom you wouldn't prescribe a stimulant medication to. And so I think this is pretty accurate. No offense to Chevy owners.
Before we launch into questions, one thing I forgot to mention, next week is Academic Achievement Day, so instead of having a formal grand rounds, we'll have posters available for you to learn about the research that's happening at Providence
With our faculty and residents and pharmacy colleagues. So I encourage you all to come. It should be a really great session from 7:30 to 9:30 Wednesday next week. Thank you. So we can take a few minutes for questions.
Yes.
Has the incidence of this condition changed over the years, like 30, 40 years ago, with the psychiatric literature?
Yeah, so it's a good question. And the diagnostic criteria have evolved. And they've become, I think, more, there's more validity to the diagnostic criteria now than there was in the 80s. So I would say based on what we know about the disorder, I think we're better at diagnosing it. I don't know if the actual incidence of the disorder itself has changed. I know there's been a lot of question about that, but it's hard to sort out with our increased awareness of the condition. But the idea that this condition existed dates back decades to the 50s, 40s, 50s, and 60s.
What's the family relationship with siblings, and why the male dominance?
So that's a good question. So the question is why is it more common in men and boys than in girls, and what was the other question? So with a primary, first-degree relative, 3 to 5-fold increased risk with a first-degree relative, whether it's a sibling or a parent. And why is it more common in boys than girls? I mean, there's question of, do boys present differently than girls? Are they more hyperactive and impulsive than girls? And so are we more likely to, identify the problem based on their hyperactivity and impulsivity? Therefore, is there sort of this false positive, and not false positive, but are we more likely to diagnose it in boys than girls because they tend to present behaviorally? And I actually don't know the answer to that. Hi.
That's a very nice talk. But do you have any sense of how it would look like in a geriatric population?
So how might it look in the geriatric population? So as a geriatric psychiatrist, I sometimes get 80-year-olds coming to me asking about a stimulant for ADHD. I have never prescribed a stimulant for an older adult for ADHD because if you think about the disorder, it's hard to make the case that an 80-year-old has occupational dysfunction due to ADHD when they're not working. But they have hobbies, and sometimes they'll say, but it makes it hard for me to like knit or to do other things that they might do hobby-wise. But I just, I don't know if I'm just biased against prescribing stimulants to older people because of the cardiac risk, but I still don't. Yeah, I still don't. I usually will refer to like a speech pathologist to help with, non-pharmaceutical interventions to assist them in whatever their cognitive struggle may be. And more often than not, their cognitive struggle is not from ADHD. It's from white matter disease or an incipient dementia or depression. So if I think that this seems more like depression than ADHD in an 80-year-old, I might prescribe bupropion or Wellbutrin or a different antidepressant medicine. But I've never, and I've been, seeing older people for fellowship was 8 years ago, and so I see a lot of older people, and some of them have asked about ADHD, and some of them have been insistent that they have ADHD, and I don't prescribe stimulants.
Without getting into his politics, I'm convinced our current president has ADHD. His lack of filter and impulsivity, his lack of attention, unable to read books. Would you comment?
I plead the fifth. I don't know. I can't. So I think that's a really good question because very often a person presents a particular way and we want to come up with a diagnosis. But psychiatric diagnoses should never be made in a vacuum. We have to consider the whole history. So if I discovered that, that these symptoms started in childhood and persisted through adulthood, and that there were accompanying symptoms of ADHD, then I would make the diagnosis. But because I just know our president cross-sectionally based on how he looks now, and I would refrain from venturing a guess about what psychiatric illness he may or may not have, because psychiatric disorders are really we have to consider the longitudinal history. And so I avoid venturing. I mean, it's fun to venture guesses about what condition he might have, and ADHD is not the one I was thinking of. But I would avoid making the diagnosis just because I don't know anything about him. And really, to make an accurate psychiatric diagnosis, I would need to know more about the person. But cross-sectionally, he does present with symptoms that look like ADHD. But remember, there's symptom overlap between ADHD and a lot of other psychiatric and sometimes non-psychiatric conditions.
Any comments, just a comment on the over-prescribing of ADHD medication? There's some studies in small liberal arts colleges where 50% of the kids are using ADHD medicines and on SATs tests and ACT tests. And it's not, as a family doc now, more and more kids and parents are bringing their kids in feeling like they're at a disadvantage because they're not on these medications. Yeah. And of course, you don't prescribe them and then they get all angry. But just any sort of...
That's a great question. Yeah, the use of stimulants as cognitive performance enhancers. So the American Academy of Neurology, their ethics division came out with a statement in 2009 that said it was not ethically wrong to prescribe stimulants as cognitive performance enhancers, but it was also not ethically wrong to not prescribe them. So they really left discretion basically up to the provider. And stimulants are not benign medications, and so I would liken it to like growth hormone. Do you give a kid who may be short growth hormone to make them taller? I think that question's come up before. Like, can you give growth hormone to kids to help them achieve a higher, to help them to become bigger? And you wouldn't do it because growth hormone causes all sorts of problems, and stimulants cause problems. They're not benign medications, and so when I've been asked, when I suspect that might be the motivating reason for an ADHD evaluation, or even the outright stated reason that my friends are using it and it helps them, I want something that's going to help me, I won't prescribe it because they are not benign medications. So that's my rule of thumb. But you wouldn't, apparently, according to the American Academy of Neurology, be faulted for doing it or not doing it. So you have leeway.
And this prolonged use of these stimulants. You have kids that started when they were 7 and they're on, 15, 20 years. Any side effects, and what are your thoughts on kind of stimulant breaks?
So I can't comment on the pediatric literature because I don't treat pediatric patients, but my thought on stimulant breaks are that they're very worthwhile. And what I often find is that people with ADHD tend not to want to take the medication all of the time, or they're forgetful in taking it. And so, when they don't need to take it, like the weekends or spring break or, vacation, they're often happy not to take it. And I give 2 thumbs up to that. If you don't need to take it, don't take it. If you're going to be on vacation and you don't need to focus and stay on task, it's fine not to take the medication when you don't need to take it. And long-term consequences in the adult population, nothing that I know of. I think in the I don't know if there are any pediatricians that are here that might know the data better than me, but there's concern about suppression of height, but I don't think that that's ever panned out, that use of stimulants is associated with shorter stature. But then weight loss is a problem because they can suppress appetite. So if I were prescribing to a kid, I would want to monitor the weight closely and probably provide more drug holidays than to an adult, because they do need to maintain adequate nutrition for growth. But I don't know if pediatricians in the population field. Do we have any pediatricians here?
Yeah. That was something I always monitored carefully, but I think you're right. The appetite suppression was an issue.
Yeah. Yeah, and the effect of poor nutrition on growth, I think, is a bigger issue than the medication itself causing changes in the person's height. Yeah, that's a good question. I'm sorry, I don't know the answer to it. But in terms of long-term consequences in adults, there aren't any that I know of. Okay. Thank you. Oh, thanks. Thanks.